Testosterone replacement therapy is a huge topic in men's health, but today we're going to talk about it in the context of prostate cancer. So I'm interviewing Kristin Geiger, who's a nurse practitioner who specializes in prostate cancer. She has a ton of experience in giving men testosterone replacement therapy after they've been off treatment, and she talks about quality of life, she talks about the ins and outs of how you take it, what you monitor for, and what to do if there is a PSA rise. We're going to get into it today, but I hope you find this informative. So today we're talking about testosterone replacement therapy, and this is a huge topic because a lot of men want to know, in the prostate world specifically, if they can take testosterone replacement therapy if their testosterone has not come back after hormone therapy, or maybe for men who are not prostate related, they just want to get some extra testosterone, and there are a lot of benefits, feeling younger, having more muscle mass, there's all sorts of things that we can get into. But can you just break down what testosterone therapy really is and what type of drugs are used when it comes to that?
Testosterone replacement therapy is a way to mimic what your body would naturally produce. And so we give it as either an injection or a cream or a gel that's topical. Typically, we kind of base those decisions based on what the patient would be interested in doing. And then some of the cash prices are a little bit different. It's a little more expensive to buy the creams or the gels than to get the injectable. Injectable is much less messy. You do it once a week. However, the daily topical dosing is a little bit more natural in that it would mimic a man's natural hormonal production, where testosterone is higher in the morning and kind of drops off throughout the rest of the day. And so when we kind of talk through that, we say ultimately patients feel pretty similar, but a daily dose is more what a body would naturally produce. And then you might not experience as high peaks and low troughs. And so the weekly shots don't really get high peaks and troughs. And when patients don't want to take the medication at home in any capacity, we also, can have them come into a doctor's office and get that shot every 2 weeks. But that's when we see a little bit more of I feel really good. And then it kind of will drop off after the 2 weeks. And so it's really, we'll monitor how high the testosterone will go or how low it will go. And then we'll kind of titrate that dose too.
So what is the dosing when it comes to, let's say, the the creams or the gels?
Creams or gels are usually, 1 or 2 pumps a day, or, one topical application a day, depending on, it's usually a 1% or a 1.62% gel is what the standards are, I think, from pharmacies.
So there's a lot of, controversy when it comes to, and maybe it's more from a misunderstanding of how prostate cancer works, but a lot of people think, if I've been on hormone therapy and we're taking away testosterone, why in the world would I add testosterone? Won't it make my cancer grow? What do you tell patients when they encounter this?
So I had a patient yesterday, actually, and he had been thinking about doing the testosterone replacement. He was post-treatment, and we were actually expecting his testosterone to recover naturally, and it hadn't. And so those are the best candidates where they're post-treatment, and most patients would have actually already recovered their testosterone at that point. And so we're saying, let me see if we can give you a better quality of life and give you testosterone that you would have naturally been producing at this point anyway. Yes, prostate cancer is fed by testosterone. So anytime you introduce testosterone into someone who no longer, has any testosterone, you're at risk for waking up something that is already there sooner or faster, but it's not going to cause cancer. And so that patient yesterday, he was saying, I saw my other physician and they told me, prostate cancer, you want testosterone? Never, no way. It's an absolute contraindication. I was like, that's because he does not specialize in prostate cancer. That his only association with prostate cancer is prostate cancer, testosterone, bad. And so he's just going to tell you that. I respect him for that because he's warning you of what he knows to be true. And so he's just like, hey, what are you doing? Let's think about this. And for us who deal with prostate cancer all day long, we're just saying, you're post-treatment, your testosterone hasn't recovered yet. Let's give you some testosterone. But we'll talk about the risks. Is it going to wake something up? Is there anything left to wake up? How soon will something rise if the PSA is going to rise potentially?
So what is a normal testosterone level and then a testosterone level for somebody who's been on hormone therapy that is not recovering?
When you're on hormone therapy, the testosterone should ideally first be less than 50, But standard is to get it less than 20 or completely undetectable. And that's androgen deprivation or ADT, testosterone inactivation. There's different little, words for it. I know our lab. So our lab's normal range for normal testosterone is 212 to around 900. And so that's a very broad range. And so for someone who's post-hormone treatment and they've had undetectable testosterone, which is less than 20 usually, typically what I've seen is that it'll start to rise as their body naturally produces testosterone again. It'll go from 20 to 50 to 180 and then into the normal range. So it is a little more gradual. And then sometimes what we'll do is we'll compare. Where was your testosterone before treatment? Is it 500, 600, and now you're just back and it's only at 200? Or is it all the way back up? Or is it kind of like fluctuating? And so we'll also talk about what time of day did you get your testosterone drawn? Earlier in the morning, it's going to be a little higher. And so maybe come back, in the morning if you want the highest that it's going to be, we'll get a testosterone then. The other point is that the testosterone being on the lower end of normal versus the higher end of normal doesn't necessarily impact how you feel. I'm like, you're in the normal range, you got testosterone, it's normal. I don't care if it's 240 or 900, you have enough that, if something was going to wake up, it would wake up. Even at 200. Sometimes we'll talk about like, hey, the patient will say, I'm still feeling sluggish. I still don't have energy. I still take a nap. I'm not really going to the gym. I'm like, well, your testosterone is like towing that line at 200. So you're there, but I think giving you a little bit more would go really far. And even at 200, if there was something in terms of the prostate cancer to wake up, it would be waking up. And so if we give you more, maybe, would it wake up faster? I just think it would be important to say, let's get you back your quality of life. And we'll deal with that if it happens, and we have plans for that, and that's not the end of the world, and that's not even changing your overall survival or your outcomes with prostate cancer. But, let's talk about it. If your testosterone doesn't match pre-treatment levels, or you're still feeling testosterone side effects or the lack of testosterone side effects.
I love how you delineated between the two, because I think a lot of people think that their testosterone has to be a certain number versus it's such a vast range. And when it comes to that range, do you really just have that quality of life conversation with every patient with how do you feel? And is that really the determining factor where you'd open up that conversation?
It really is subjective. You talk about someone about what are you going to feel on hormone therapy, turn it on its head and say, what are you going to feel off of hormone therapy? You should see your fatigue go away. You should see your hot flashes go away. Your libido should come back. Your bone density should improve. And so we kind of walk through, are you napping? Are you exercising? Are you fatigued? And if they're still feeling a lot of those things, they really might benefit from having some more testosterone.
So does testosterone replacement therapy work in everyone? Like if you give the testosterone, it's going to work? Or is there a certain percentage of patients where you can give them testosterone and it won't work at all to raise that level?
Typically, if you give testosterone, the level will rise. Whether or not their subjective symptoms improve completely or are only mitigated, that's really patient specific, because you need to be active to feel better too. And so a lot of us emphasizing exercise and activity is that lends itself to just an overall quality of life and a feeling of well-being. And so when you have testosterone added to your situation, you actually might feel better and be able to then go exercise and be active again.
So you mentioned earlier that, we have the creams, we have the gels, and there's also injections. Where do they go for the injections, or are they doing it themselves?
They can go into a doctor's office to get an injection. In our office, we give it either subcutaneous or intramuscular. We have a little bit of difficulty though. The standards is to give it into a muscle, which is a pretty intense injection in terms of it's deeper and the needle's a little bigger. And so when we prescribe for patients to give it to themselves at home, we'll sometimes opt to do it subcutaneous, and pharmacists are not aware that that is possible. So we'll get a little bit of kickback saying this needs to be an intramuscular injection, and we'll kind of, well, either way is fine with us. So usually when I teach patients to give it to themselves, I'm teaching a subcutaneous into the fat injection. It just will go into the stomach, which is really accessible.
They're picking this up from a pharmacy, they're bringing it home, and if it's subcutaneous or it's into the muscle, are there any things that they need to know about? Or is it really just, making sure you're comfortable, and are there certain spots that they need to put it in, or anything they need to avoid?
I'll have a patient and I'll walk them through how to give themselves an injection or send them a PDF of here are your instructions. I'm sure there's YouTube videos too. Some of the things that are good to be aware of with testosterone is that it's very like thick and oily. And so when you are giving an injection into the fat with a smaller needle, it takes a little bit more force, a force to get through that smaller, opening at the end of a needle. The other thing that has been difficult for patients is when you draw the testosterone out of a vial and you've inverted it and you're pulling down on a syringe, the top of your syringe needs to be submerged in the liquid, and being able to see that because that opening for the needle is at the top. And so walking people through that, we just kind of do it together essentially.
What are the side effects of taking testosterone replacement therapy?
I think there's maybe only one negative side effect that we actually monitor for pretty closely. Testosterone is a building block to red blood cells, and so you can actually end up having what is called erythrocytosis, where you make more and too many. We check the blood work every 6 to 8 weeks after initiating just to see if that's happening, and then based on their levels, space out when they come back to see us. The red blood cells, if they do get too thick, we can do a phlebotomy or have them donate some blood just to, thin the blood a little bit. Sometimes patients will be put on aspirin, and we can titrate down the dose of testosterone, maybe do it less frequently just to see if it builds back slower. One of the goals of doing a phlebotomy, which is a blood draw, which is a substantial amount of blood, is to actually get them to be a little bit iron deficient so they can't build up blood cells as effectively. There's so many different building blocks to red blood cells, and so for a while testosterone was lacking, and so patients can be mildly anemic just from hormone therapy. And so when the testosterone is back, they're like, oh, I'm going to make more red blood cells. So we're like, okay, then let's limit the iron. So then that'll keep it kind of stable, which actually ties into, the diet we sometimes recommend for prostate cancer is lower in the animal fats and proteins. And so we'll say, even for this, you should limit your red meats because that has a lot of iron in it. And so we'll talk about a lower iron diet as well.
So what percentage of patients do you see make those extra red blood cells?
20 to 30%. So it's significant enough that every patient we put on testosterone will check and monitor. And it can happen a little bit further down the line. Hormone therapy can actually cause mild anemia. So if they're already starting from a little bit of a deficit, when they get testosterone, they come out of their deficit. But then if it causes that overabundance, it's going to take a little bit of time to really just build it all the way up. Red blood cells are produced every 120 days, at least monitoring every 3 months at first. And then if we're confident that their body is not going to make too many, sometimes we'll just check in every 6 months.
So for patients in this situation, maybe they're in that 20 to 30%, what would be the cause for concern, since if there are more red blood cells, what would happen if that did, occur and it wasn't being monitored?
Having too many red blood cells is bad, ultimately. When your blood is thicker, it's more likely to clot, and especially if you already have some of your arteries narrowing a little bit, so you're much, much higher risk for heart attacks, strokes, thrombosis, pulmonary embolisms, all those awful things that could really impact your long-term longevity.
So as far as monitoring goes, when I think about a prostate cancer patient who's going on testosterone replacement therapy, they need to keep getting their PSA checked. They need to check for, their blood count and make sure that their red blood cells aren't too many. And then they also need to check for, the testosterone levels. So we have those three things kind of in combination. How often are you checking them as far as a monitoring and sequencing in time?
You're right to bring back to the prostate monitoring side of it. When we put someone on testosterone and, they're post-cancer treatment, they're seeing how they're doing. Initially, for at least the first 2 years, we're going to be checking a PSA and a testosterone every 3 months.
And that's without even taking the testosterone therapy.
Even without, yeah.
Okay.
When we add it, initially, that 6 to 8 week visit after initiating testosterone. And then depending on the PSA, really, we'll do more frequent or at least every 3 months. Some patients want to see more data points just to really track trajectory and rise over time. And some people, it's actually better for them not to do that. And so if I have a patient saying, hey, can I have a monthly script just to go get my PSA and testosterone checked every month? Totally willing to do that. But if everything is stable, PSA is remaining undetectable, I really won't push for anything more frequently than every 3 months.
As far as patients who are on testosterone replacement therapy, as if the PSA does rise, and you're not saying it's caused by the testosterone replacement therapy, it would be because the cancer is, either in a metastatic state from in their blood or something, whatever causes that PSA to rise. At what point do you say your PSA is rising, we need to get you off of this?
We actually don't just jump to taking patients off testosterone right away. I'm sure you've talked about it on many other videos. The beauty of the new scanning technology, like the PSMA PET scans, they're sensitive down to a PSA of 0.2 to 0.5 initially. And so if the PSA budges at all, we'll say, okay, is it in the 0.2 to 0.5 range? Because then we can just get a scan and see if anything lights up. And it's so small at that point that if there's one spot, we could potentially, radiate it. And that's a whole other discussion. And all of that, we would just leave them on the testosterone at that point because their body would naturally have been producing testosterone anyway. If we take them off testosterone and the PSA plummets, then the scan potentially would show nothing and we wouldn't know if there was a recurrence or not. And so in some ways it helps us really know what's going on inside the body to go and get a scan if we're really concerned that something has come back, as opposed to just taking them off of testosterone. I do have the patients in the camp of, well, I'd prefer not to worry about my PSA and to have a poor quality of life. And I would just want to stay off testosterone because, if they've gotten scared, the PSA bumped up a little bit and they went off testosterone, went right back down. And they're like, we're just going to, status quo and just go forward and not have testosterone. And so it's really patient preference too. It is scary to have a rising PSA in general. And so they'll take themselves off of testosterone too. And we'll kind of talk through that. Well, maybe you could do once a month and see if the PSA is stable. And we'll titrate that dose too.
So there are a lot of factors when it comes to testosterone. And really, you've said it well to me in the past where it's that idea of function versus interest. Some men, they're coming off of hormone therapy and they haven't had any interest, and all of a sudden it's starting to come back with testosterone. So how do you describe that to patients?
What I tell patients with testosterone is one of the signs that your testosterone is back into the normal range or at a good dose if you're on the replacement is that you're interested in sexual activity again. You start to have that awareness come back because when you're on the hormone therapy, it's blocked, your libido is down. I do also tell them that the function doesn't necessarily improve and it's not dependent on testosterone. And so taking testosterone doesn't improve ED. It doesn't bring back function that has been lost. But one of the reasons we prescribe like a daily Cialis during hormone therapy and even emphasize, if you can be sexually active during, a lower desire is so that you can maintain function. The functionality is just based on like musculature and some of the other things, but part of sexual activity is also just, the brain is part of it. And so if you're interested, that will also lend itself to better outcomes.
Is there any counseling you do for the partner? Because, if they may be going through the situation where they've had no interest in sex and now all of a sudden he is interested. And that's kind of a big shift compared to somebody who's been on hormone therapy for a couple of years.
When I'm dealing with an older couple, where maybe changing their sexual activity during treatment has been a big change for them and they are comfortable with that or they're happy with that. It takes two to really have that all go well. And so we'll say, well, what are your priorities together? Where are you both at? And if I need to talk to them individually, I can too. I've actually had a patient say, my wife is not interested or not medically capable anymore, so it's actually better to be on a little less testosterone so my drive isn't as high. And so that's something we'll talk through too. For a woman, as she gets, ages and goes through menopause, and so we do also offer, there's the bioidentical hormones for her that she can try and see if she can increase her interest or her drive and her enjoyment of it as well. And so it's really couple dependent where their priorities are. Men and women think about it differently. The priorities can be different. And so there's a lot of counseling actually when it comes to being on hormone therapy, because there's a partnership there that needs to be worked through of what are our goals. Is this causing a rift? Is this causing pain? Where's my identity? What's our identity as a couple? And so you kind of have to work through a lot of those things as we change men's sexual interest or, give it back or take it away.
What type of counseling do you suggest that patients get who are either maybe coming off of hormone therapy or even on it, or are going to take testosterone replacement therapy? Is it couples counseling? Is it a mental health professional? Do you ever find that necessary?
I have found it to be necessary for some patients where I would recommend a licensed therapist to talk through a diagnosis, or you end up feeling so much different than you felt before with like a hormone therapy. We have patients who either that he had struggled with anxiety or depression and it just really exacerbated it. And so we say, well, maybe, you know, consider going back on a medication you tried in the past, or increasing a dose, or finding someone to talk to just about, you know, your mental health all the time. And I think part of when I've read some of the survivorship, like online blogs and people sharing their experiences, for me as a provider in a practice, one of my goals is to make patients feel like we haven't abandoned them. And so when we see patients every, 3 months initially after treatment, it's a really like, how are you actually doing? I get a lot of patients saying, I don't mean to complain, but, and I'm like, no, this is where you can complain. This is where I can tell you that's normal. Oh, that's a little bit more intense than I would have expected. Let's talk about that. And so actually walking them through that after treatment can go really far. Or having a patient come in and say, hey, I'm feeling this way, and being able to draw from them what's actually going on in your life outside of this. Oh, there's a lot. Oh, you've had a grief and a loss, and this is part of normal grief. And being able to say, you're grieving, that's normal and hard, and just be like, you want to talk about it? And so I think as providers, we can actually lend a good amount of service in terms of just listening and saying, we hear this, you're not alone. Maybe check out a support group. And now that, the world has opened up again and there's a lot more in-person things, there's people to talk to who've been in your shoes. You're not the only one with this question or with this side effect or with this like identity, shift. The other benefit is that there's also support groups that are meeting virtually. And so if it is a little harder for you physically to go and meet with people, you can join something online too.
One of the things that Kristin said that really stood out to me was how much quality of life matters. If you've been off of treatment and maybe you feel like you're still not interested in sexual activity, maybe your energy level isn't just what it should be or you think it should be, it's an important thing to talk to your doctor. So what I would do is I would write down, what are my priorities? What do I want my quality of life to look like? What side effects am I concerned about? And that way you can go in with your medical team and say, hey, this is what my concerns are. This is what my priorities are. How can you meet me where I'm at? And, maybe it is an option for you. Maybe it isn't. But at least you can have that conversation and even just get the questions answered so it's out of your head and you kind of know what the next steps are. It's always good to prioritize your quality of life and make sure that you're not suffering in silence with something that can easily be fixed. And it's really important that you bring in, somebody with you, a caregiver, or even record those sessions so that you can go back and listen and say, this is how they answered the question. And at least I know that here's my answers and I feel good about this. Doing your research and being empowered with information is the best way to have the best outcomes with your medical team. So I would really encourage you to do so. Now, if you need help doing research or getting your questions, sorted, our PCRI helpline is a great way to do that. You can find out more at pcri.org/helpline. These are prostate cancer patients who have been through this, and they are a fantastic resource. If you would like to learn more about prostate cancer in general, you can learn more at pcri.org. And please subscribe to our YouTube channel. We come out with new prostate cancer videos every week. The number one thing I want you to remember is that you're not alone. We appreciate you for watching, and I hope you have a great week.